Welcome, everybody. I'm Bonnie Maldonado. I'm the Chief of Pediatric Infectious Diseases here. And it's going to be, I'm really excited and looking forward to hearing our infectious disease guest speaker, visiting professor from Baylor, and we'll talk about her in a bit. We have the privilege of having Dr. David Lewis, our distinguished colleague, immunologist and infectious disease physician, who's going to talk about severe influenza viral infections, novel vaccine and gene therapy approaches. This is an area he's been working in for most of his career, especially in the area of adjuvants. And also, just as a reminder, as of yesterday, what's today? No, 2 days ago, the flu vaccine is now available in the hospital and occupational health. So please get vaccinated for flu. You'll get a little, I think it's a silver dot this time on your badge so that you can have entry to the hospital. I think we're going to stop vaccinating at the end of October. And then the next week after that, October 4th, it will be the 7th Annual Educational Forum. Am I teaching clinical reasoning with Gurpreet Dhaliwal from UCSF? And for some reason, the October 11th just says Pediatric Grand Round, so that'll be a surprise topic. We'll find out more about that. Maybe it'll be a Halloween theme, I don't know. Then for Pediatric Grand Rounds, there's a new opportunity to do your online attendance registering, introducing text attendance, so it'll be starting later. I'm not going to give you all the details, but the phase 1 will start this month and next month so that you can eventually just text in your attendance. You don't have to sign in. There will be a transition from paper to online attendance, and you will earn CME credit. There's also the engage sessions for faculty and staff, and these are around engaging in leadership, educational scholarship, and there's also an educational scholarship think tank. And the one for September will be September 24th. Our own Tom Collins will be talking about what is leadership and what it isn't, creating your leadership map. And then Becky Blankenberg on October 7th will be talking about what is educational scholarship. So this is very helpful, especially for our trainees and our junior faculty, to really get some roadmaps around how to build your leadership potential. And I think all of us, no matter what stage of our career are in, can always learn more. Don't forget to register for the 7th Annual Educational Forum, Innovations in Medical and Bioscience Education on October 4th. This is going to be very exciting as well. This is the MCHRI annual, 2nd Annual Research Symposium. And this year we are privileged to have Diana Bianchi. And I don't know, some of you remember Diana. She went to medical school with me here at Stanford. She is at NICH. She's the director of NICHD, but before that she had a really illustrious career as a geneticist at Boston Children's Hospital and did a lot of exciting work. She's going to talk about the earlier the better, using precision medicine to develop fetal treatment. That was an area that she really started in and really developed some novel new techniques. She will be the keynote, and there are many other faculty listed here that are our own pediatric and other OBGYN colleagues. So please, if you're in town, please try to get to that. It's a really exciting opportunity. And then finally, visit cme.stanford.edu for other opportunities, including our Pediatric Dermatology and Ophthalmology 2020 session. Now, it really does give me great pleasure to introduce Dr. Flor Munoz. Dr. Munoz comes from Guatemala originally. She did her undergrad medical school training there, but she did her internship, residency, pediatric ID fellowship at Baylor in Texas, and she is now close to being a full professor at Baylor in pediatric infectious diseases. She is a member of our Red Book Committee. I'm the chair for the next few years, and she's been a fabulous member of the committee. And I'll just say right now that if you have any questions later on about flu, she wrote pretty much word for word this year's flu statement, which is 70 pages long. So she is a fabulous writer and knows the literature very well. In addition to that, though, she has a very long career in maternal immunization, and she'll talk a little bit about that today. She's an amazing font of knowledge. She does a lot of work in global health around respiratory infections of childhood and the potential impact of maternal immunizations on global child health as well as health of U.S. children. And she's a strong advocate and researcher in this area. So I'd like to welcome Flor and help me welcome her as well.
Thank you, Bonnie. Really appreciate it. Thanks. Well, good morning. Thank you, Bonnie, for that kind introduction and also for the invitation to be here with you this morning. And I will speak with you today about a topic that, as Bonnie said, is dear to my heart because I've been working on it, even though I'm a pediatrician, with vaccinating pregnant women. And I represent in this topic a lot of people actually just came from Vancouver, where we had our INMIS, which is an International Neonatal and Maternal Immunization meeting, where you see a reunion of the minds, everybody that works on maternal immunization all over the world. So it was really, really enlightening. And so I am going to well, these are my disclosures. You saw them already. I'm going to give you just a general overview about maternal immunization in case you haven't been involved in this area. Talk about what it means for maternal and newborn health throughout the world. We'll talk about a few cases. In order to introduce the concept, we'll talk about the case of tetanus. And then to talk about what we currently do, we'll talk about influenza and pertussis briefly. And we'll also look at new horizons, what is coming up in terms of new vaccines. You see, it's a pretty packed type of agenda, so we'll touch on some of the key points if we have a chance. So I will start by saying, the UNICEF just put out their most recent data regarding our progress in terms of data related to pediatric mortality. And if you look at these numbers, you can see that we're in pretty good shape. We have had globally a decrease in pediatric mortality of nearly 53%, so more than 50%. And the numbers that you see here indicate that from 1990 to 2017, all the indicators are coming down and the numbers are coming down. However, if you look at under 5 mortality, we continue to have over 5 million deaths in children under 5, mostly in the developing world. And what is really striking is that almost half of them, 47%, 2.5 million, are neonatal deaths. So this is where the concern is from a global perspective, that there's something we need to do about this. Obviously, the distribution is pretty uneven. We would expect Africa and some of the Asian countries, some in Latin America as well. That's my country right there. So this is definitely an interest to me in particular. And neonatal mortality, you see it actually matches exactly the same way. Maternal mortality is also a big problem. And so if you think about it throughout the world, we continue to have an issue where you see the numbers there. There would be almost over 300,000 maternal deaths in the last time that it was reported in 2015. So more than 800 deaths per day in the world. And even with the decrease that we've seen since the 1990s, this continues to be an issue, right? So this is what the UN has said, that in terms of goals to attain sustainable development in the world, there would be an important target to reduction of the global maternal mortality to numbers that hopefully will be achievable, as you can see, very, very steep decrease, less than 70 per 100,000. We are right now at 216, so that's a pretty ambitious goal. And the other ambitious goal is to actually end, not just reduce, but end preventable deaths in newborns and children under 5. To do that, the idea is also, again, obviously to reduce neonatal mortality and under 5 mortality. And this is where maternal immunization comes into place, because all maternal and infant initiatives and health goals would be also targeting this global sustainable development goal. So most of you have seen this graph. A lot of people that talk about global health show it to you, and it's just, again, trying to focus a little bit more on the causes of mortality in under 5. And under 5 is on this side, and neonatal is on this side. And of course, these are just estimates and numbers that may vary time to time, but I will point out to you that both in the under 5 mortality and also in the neonatal mortality, other than birth complications and prematurity, the most important causes are related to infections. This is where we come to place. Some of them respiratory, so pneumonia is a big problem. Some of them gastrointestinal, many of them that can be prevented potentially with different interventions. So the rationale, why do we worry or why do we think about maternal immunization as an opportunity to impact this? As I've shown you, if a child has any risk of mortality early in life, it's going to be greatest in early life, especially the first month of life, which is quite outstanding. This is a reality in the entire world. We also know that young children, especially infants, don't have a very good antibody response to their active vaccination, in partly due because of maternal antibody, but also that when you have a specific antibody from the mother, it gets transferred to the placenta, and then that provides the protection that babies need to survive those early life insults or experiences. So we have many examples of that. As you can see, I've listed some of the organisms there for which epidemiologic data shows that. So infants do depend on the maternal antibody. And the good news is that, even though moms might have low antibody concentrations, as we saw, for example, with pertussis, they actually do respond well to vaccination. And we know that the antibody is going to be transferred to the placenta to the baby. So there are many opportunities during pregnancy to try to boost those antibody levels. So this is the concept, and I've summarized it very briefly here, where you can see that essentially we are boosting levels of antibodies that were already existing because moms have either been infected or they've had their own vaccination. So they might start out with a low concentration, usually of IgG antibodies. By providing maternal immunization, you increase those, you increase the transfer, and you decrease this period of vulnerability, which is the time that the infant takes to develop their own immunity through active immunization. And that's it. Some vaccines are given to the mothers, like influenza, mostly to protect them. Some vaccines, like tetanus, and maybe in the future group B-Strep, would be given mostly to protect the infant because the disease happens so early that there's really no time to do other interventions. Although we have interpartum prophylaxis, you can see that it hasn't really taken care of, for example, of GBS late onset disease. And some vaccinations we give to the moms are specific to actually try to protect the infant. The most clear example has been pertussis, but we will see how influenza can do that too, and in the future, potentially RSV. Okay, so that is the framework. This is where it would fit in terms of maternal and infant global health. There's a continuum between the mother and the infant, and that susceptibility zone, and usually the first 3 months of life where you have greatest risk, because if you have low maternal antibodies and no infant active immunity, you'll be susceptible to these infections. So maternal immunization here would provide protection until the time the infant immunizations will provide that protection over time. And clearly, the antenatal care and the pediatric care provides a continuum for this intervention to occur. Simple as that. So I'll talk a little bit about what we know about transplacental antibody transfer. This is a very active topic of research throughout the world, and there are people doing, placental models and all kinds of things to try to understand this, which we had maybe taken for granted over time. But we know that the transfer of antibodies through the placenta is actually an active process. It's like a pump. It's mediated by a receptor, FC, a neonatal receptor, and it's specific to IgG. So the transfer is such as, if you see this is a natural antibody, maternal antibody to hepatitis B and cord antibody, you see that there is a linear correlation. The higher the concentration in the mother, the higher the concentration in the baby. And the transfer begins usually around 17 weeks of life, but it does become more efficient at the end of the second trimester, and then continues to increase until delivery, so until term. And we know that certainly, the fetal side, by the time of a baby's term, it actually can have a higher concentration of those IgG antibodies, because that is a natural protective process that is in place. The half-life is about 30 to 40 days of IgG, so clearly if you have higher antibody concentrations at birth, you have potentially a longer duration of protection. So that's what we know of for a certain time. Where does this all happen? So this is a picture of the placenta. You can see there's a fetal part and then there's a maternal part, and everything happens here in this syncytial trophoblast region, where the syncytial trophoblast actually expresses that neonatal FC receptor. And what you can see is that basically there is a trying to illustrate that here. The antibodies come through the maternal circulation, and then eventually they get, they become an endosome to be able to be transported to the fetal site through transcytosis. So this is a process that is active, again, and I like to call it as a pump, because really the natural evolutionary mechanism is to have all of that protection provided to the baby. Anything that is there, even if it's very little IgG, is going to try to go to the baby side. There are some things that affect this process, though. So there are some limitations to maternal immunization, of course, right? So I mentioned, for example, the gestational age is important. If a baby is born prematurely, they are not going to benefit as much from that transfer of antibody. They'll have lower quantities of antibody. We also know that the interval is important. So we know that, for example, with pertussis, if you vaccinate a mom and she delivers within a couple of weeks, there will not be enough time to get enough antibody response and to provide that antibody to the baby. So that is clearly important. And then the levels of antibody. The subclasses are interesting too. So it's IgG, so it's only for IgG. And within those, this is some older studies showing that for IgG1, for example, if you go from 33 to 40 weeks of gestation, you have clearly a higher concentration at the end. But that is not true for IgG2, for example, or 3. So there's a preferential transfer of certain IgG subclasses, which is critical when you're thinking about vaccine development, as some vaccines might, produce different types of IgG. And so those that produce IgG1 would be particularly more efficient for maternal immunization. More recently, and this is some of the work that was presented at IMIS just this week, investigators are looking at even the conformation and other factors that could affect this transfer within IgG. And one of them is glycosylation of the IgG. And so, remember this is a monomeric, so you have an FAB domain and FC domain, which is a constant domain. And it turns out that there are different types of glycosylation that make it very specific to be attaching to the FC receptor. And within the subclasses, there could be a difference between them, and that's how it explains the preferential transfer of IgG1, for example. So lots of work going on that. It's really beyond what I normally do, because this is for basic science, but I'm letting you know that people, again, have different models that they're working on to optimize this process. From a clinical perspective, there are also other factors to consider. So obviously, placental abnormalities. A placenta that is not healthy is not going to be working as well for this. And then there have been infections that have been associated with decreased transfer as well. One of them is one of the most important in the world. It's malaria. And this is a nice figure that shows you in a study that was more than 20 years ago. You see that, again, the cord to antibody to maternal antibody ratio. When you have no infection with malaria, you have that linear correlation and with high concentration on the baby side. But if you have malaria, the higher the parasitemia, you see that the lower the transfer to the baby side. So that is just, again, a sick placenta. And the same thing has been noted with HIV infection, just because, women, not necessarily because the placenta has a problem. This is work by Chrissy Jones from the UK, where they looked at women who were infected with HIV and exposed but not infected babies, and women that were not infected and not exposed babies. And you see that the concentration of antibodies to different pathogens in the placenta is lower, even if the babies were not infected, just the mothers, by a reduction of anywhere from 15 to 40%. So again, important to keep in mind, because this could be limitations for application of this intervention throughout the world. One other point about transplacental transfer is this, where you see this is measles, this is L-Toleridan from Belgium, that looked at just natural immunity for measles, so from people who had measles when they were children, compared to immunity provided by vaccination. And you see that the time to loss of immunity actually is faster if you have vaccine-induced antibodies. So the duration of the protection might be less from vaccine-induced antibodies than from natural immunity. Something to keep in mind for the future as we continue to vaccinate pregnant women. And importantly as well, as different from mice, so humans, the majority of the antibody is going to be through the placenta. But there's also antibody that is found in the breast milk. And so this is just an added on because we continue to study this as well. Nice review here by Kristen Martens, but you see how both IgG and IgA are present in the breast milk, and they can be protective against many of these organisms. This is an example, for example, of pertussis, where you have non-vaccinated and here postpartum vaccinated, and you measure IgA in the breast milk, and it's clearly higher than in the non-vaccinated population. So that's a bonus, if you will. Okay. Vaccination of pregnant women is not new. I just wanted to tell you that because we hear it a lot these days, but it's not a new concept. Women were getting smallpox inoculations when, smallpox was a problem because there was no other option. It was a life-saving intervention. We also know that in the 1940s, when whole-cell pertussis vaccine became available, and there was a lot of pertussis, women would get studies. It was under clinical research that would give 3, 4, 5 vaccinations even of this very reactogenic vaccine. Obviously, it was not necessary to do it anymore because the infant vaccine works well. Influenza, after the 1957 Asian flu pandemic, the Surgeon General included pregnant women in the recommendations of influenza. That's how long we've been vaccinated against influenza. And then we have the story of tetanus toxoid to prevent neonatal tetanus, which started in the 1960s. And this story, I like to tell it because it's really interesting now in the context of, we're doing a lot of research. So at that time, what we knew is that in the 1950s, tetanus is a terrible disease, high mortality in babies. And we knew that there was a vaccine available that was effective against tetanus, that mothers were vaccinated and they responded to the vaccination. And then the infants, again, that were born to mothers who were vaccinated with TT had higher concentrations in the cord. But there were no other really good options to prevent tetanus in the neonates. And the study that was done in Papua New Guinea, this is the original publication, was pretty much a demonstration study, quite simple. You see here they had 3 groups. One group was where there were no vaccination given or just 1 injection. Another group, they were given 2 injections of tetanus vaccine during pregnancy. And in the other group, they were given 3 injections. So in Papua New Guinea, 3 different villages, a few subjects, less than a couple hundred in every group. If you had no vaccination or just 1, the rate of neonatal tetanus was 10%. But once you went down and you even get 3 shots, you decrease that to 0.5% mortality in neonates. Pretty outstanding, right? And so this is what actually led to the global maternal neonatal tetanus elimination initiative that was set up by the WHO. That was it. No randomized controlled trials. This was it. Okay? Pretty striking. So we know that tetanus, you give 1 dose, you might get duration of protection for about a year, but repeated doses will actually give you prolonged protection. And so the strategy is to give, make sure that pregnant women have the 5 doses of vaccine at some point in their life. This is a card from one of the countries. And the goal is elimination, which is having less than 1 case per 1,000. And it's been effective. It's wonderful. So this is the most recent figure of the 2018 from WHO that shows you that as maternal vaccination since the 80s has increased with tetanus vaccine, this should be 72% because that's what's reported, although the figure looks like 62%, so they need to fix it. But the tetanus incidence has decreased. And you see that the most recent update is that we went down from almost 800,000 deaths of neonatal tetanus to about 30,000 in 2018, 96% reduction in mortality, pretty impressive. So the platform is there. And obviously, this is a different disease from the others that we'll discuss, but there is already an antenatal care system where one could potentially introduce these new vaccines to try to impact maternal and infant mortality. So what is the guideline in the United States? What do we do here? This comes from ACOG, American College of Obstetrics and Gynecology, and the statement is simple, right? It's basically you have women who are at risk of exposure to a disease that can be harmful for herself or for the fetus, and you have a vaccine that is available, like they did when you had tetanus vaccine, then you balance the risk-benefit. And if the risk of the disease is so much greater than the risk of the vaccine, you should provide that vaccination to the pregnant women, okay? Now, keep in mind, I like to point out this is on a platform where you have already inherent pregnancy risk. So pregnancy has potential obstetric complications, but those need to be distinct from vaccination complications. WHO has a very similar statement, and this is actually what we do. So again, just being pregnant should not be a reason for a woman not to get vaccinated when her life or the fetus's life is at risk. If you have a vaccine that works for the general population, right? So usually inactivated vaccines are okay. We give them if they're safe. They will not affect the fetus. Live vaccines, sometimes there's a little bit of a concern because theoretically they could potentially go into the fetus, although you'll see, I don't have time to show you all this, but in mass immunization campaigns, for example, for rubella in the Americas, or in advertent vaccination with some of these vaccines, MMR, yellow fever, for example, there's really no transmission to the fetus. So it's generally safe, but as a precaution, they're usually not utilized. But again, the risk-benefit concept is what needs to be considered. So this is the schedule of vaccines recommended by WHO throughout the world for pregnancy. And really, the one that is recommended universally is tetanus. They're using TD now, so it's actually protecting against tetanus and diphtheria, and that's what should be used throughout the world. Influenza vaccine is recommended globally in places where there is already vaccination in place, and many countries are introducing that now as the next vaccine. In the US, clearly we use influenza and actually Tdap for the pertussis protection since 2012. And Tdap is not necessarily one of the priorities in the rest of the world because the burden of disease is not as great, and they still use wholesale vaccine in places, so it's not listed as the top. But in the middle are vaccines that are not routinely used in pregnancy, but can be given in a situation where risk is greater than benefit. So you have outbreaks, for example, and you see there's actually one that's a live vaccine, yellow fever, which indeed, could be a deadly disease. And in situations of outbreaks in South America, other places, women are not excluded from receiving this vaccine. And the ones that we tend to contraindicate, of course, we don't want to give them in pregnancy are all the live vaccines. Okay, one more point about postpartum vaccination. It's okay. And actually, that's what we do. We give MMR vaccine to rubella non-immune mothers because they need to be protected for subsequent pregnancies. And so it includes non-live and live vaccines that be given postpartum. Ideally, they want to be given during pregnancy, for example, influenza, because the protection to the baby is not going to be the same. The only potential contraindication postpartum is actually yellow fever, interestingly, because there have been 2 or 3 reports of cases of breastfeeding mothers and babies having yellow fever without necessarily clear documentation of infection. So that's a precaution right there. All right, so let's talk about implementation, and we'll talk a little bit about what we have learned from all of these infections and all of these maternal immunization strategies. So I mentioned to you the recommendations. As you can see here, the recommendations are not necessarily implemented globally. Tetanus, for example, in the Americas, just some of the countries use it. We don't use it in the US as a routine because we just don't have neonatal tetanus anymore. And in the rest of the world, you see the same thing. It's mostly in the developing world, but it's a universal strategy. Influenza vaccine recommendations, this is showing you where they are in place everywhere in America, and this is like mostly, again, in the developed world. Australia is here, South Africa, but in the developing world, in Africa is not that much implemented. And Pertussis is mostly an American initiative with Australia and UK and some other countries in Europe doing it as well. So the issues with that, I'll tell you just briefly some of the issues with immunization in pregnant women is that one thing is having a recommendation, and it makes total sense to balance risk-benefit. But to this day, there is no vaccine that is specifically licensed for pregnant women. Okay, so that becomes a problem for many countries and policymakers who are trying to give it, and they have concerns about the risk and potential consequences from adverse events that happen during pregnancy. They are recommended because they're good for the rest of the population, but there have not been going through a research process specifically for an indication in pregnancy. Okay, that is until recently. I talked to you about the risks already existing in pregnancy that could be considered related to vaccine, although they may not be. And also you have to demonstrate safety and efficacy both in the mother and the baby. So it's a huge, huge undertaking. We do, however, as I mentioned before, have the potential of having an impact in other diseases like Group B strep and RSV. So it's a potentially very impactful public health intervention that one needs to explore and not abandon. And things like experiences like Zika, for example, have really made us think very carefully about we shouldn't really dismiss doing research in pregnancy. We need to include pregnant women. So these are some of the things that the perceived risk of the vaccination actually should be balanced with the risk of not giving the intervention, right? So if we do research, we will know more about pregnant women and vaccines, just like we do for drugs, and not exclude them from this important intervention. So what I'll tell you is that there's been a lot of progress made, and I'm showing you briefly here something that could be the topic of a whole day seminar, but there has been a change in culture from the days post-thalidomide when women would not receive anything, not even pain medicine, nothing, to actually going back and saying we do need to include pregnant women in research. And that has been supported by a number of groups. There's several publications that are focusing on that from an ethics perspective and from a research perspective. This is US, this is globally, the SCIEMS group, that are talking about designing not just the clinical research, but vaccines to be given to pregnant women. And that how do we assess safety and how do we assess the responses, and all of that needs to be considered. Gaia is a group that made case definitions for outcomes that we are using for assessing safety. And then in the US, things like changing the pregnancy and lactation labeling rules so that information about vaccination and pregnancy is included in the package insert is also very helpful, and that is also in progress. Anyway, lots of things have happened, and I just wanted to point that out. I will now talk to you a little bit about each of these important vaccines we have given and just give you some points about what we have learned, okay? Flu vaccine, I showed you, it's been recommended since the 1960s. Not always in the same way, so I have a progression there, which basically went from give it to high-risk pregnant women to give it to all women. Eventually, in 2004, it was give it to all women anytime in pregnancy. And it was the 2009 pandemic that really opened everyone's eyes because, believe it or not, before the 2009 pandemic, the coverage was about 13% in the US for influenza vaccine, even though it was recommended since the 1960s. Pandemic comes along, realize that we do have a lot of morbidity in the pregnant women. We went up to 50%, so better, but unfortunately we're still at that 50%, which is not great. But globally, it caught the attention of everybody, and so SAGE, which is the group that advises the WHO about vaccination, in 2012 said we do need to vaccinate pregnant women against influenza. And this is where you see those initiatives happening right now. For example, I was just recently in Bhutan, an incredible country in terms of their health system, and they are introducing flu vaccine in pregnant women and healthcare workers as their first attempt. Sri Lanka is doing the same. Some other countries are doing the same for the mother and for the baby, as you will see. So in the US, it is an essential component of prenatal care. We should be doing it for every pregnant woman. These are some of the publications that are available. PAHO in Latin America has this, which is very helpful. They have really been at the forefront of implementation of flu vaccine in pregnancy. And this is the global guideline to do that. So the tools are there. I'll show you now some studies that have taught us some lessons, because believe it or not, even though we've been using it here in the US for all these years, the randomized controlled trials that have been done for influenza vaccination in pregnancy were not done in the US. They were done abroad. And there are 4, okay? The first one was a study by Dr. Shaman and Dr. Mark Steinhoff in Bangladesh, you see, pre-pandemic, where actually the main study vaccine was the pneumococcal vaccine given to pregnant women to decrease neonatal sepsis. And the control, mind you, was the flu vaccine, okay? And you see how, it's a small, relatively small study. After the pandemic, these 3 studies came along. Shabir Mahdi in South Africa using flu vaccine with a saline placebo. Then Nili Tapia in Mali using the flu vaccine, IIV3 inactivated compared to meningococcal vaccine. And then again, it's in the last study for Mark Steinhoff in Nepal using, again, a placebo, saline placebo-controlled vaccine. And what I wanted to point out to you, these are the studies that were done really to demonstrate that Indeed, you can have an effect. And here you see the effect in the women. First time it was shown. We didn't even have studies that showed that it worked. But if you look at the very specific outcomes of PCR-confirmed influenza, you see a 50 to 70% protection of pregnant women against the flu, similar to the general population. So it works in pregnant women. Second point from these studies, these are the same, is that it works in infants. And so these babies were followed over time, sometimes 6 months, sometimes a year, depending on the study. And you see that again with the specific outcome of PCR-confirmed flu, a protection that varied between 30 to 60%. Vaccinating the pregnant women reduces the risk of influenza in babies from 30 to 60%. Now we can tell this to the mothers, so they should get vaccinated as well, demonstrated in randomized controlled trials. More recently, I do want to show you this. This is from the CDC, Mark Thompson, and a group called Prevent, which is 4 countries that got together, US, Canada, Australia, and Israel, and looked at a large database. This is really to look at vaccine efficacy, but retrospectively. And, sadly, you see that over several seasons, 2010 to 16, over nearly 20,000 hospitalizations, only 6% of the pregnant women that came in with a respiratory illness and fever were tested for the flu. One point is that we're not testing enough, so sometimes we miss it. We don't realize the impact it can have. And interestingly, you see that of those that were positive, more than half, 54%, had a diagnosis of pneumonia and influenza. So if you test, you'll find it. So it's quite sensitive and specific. But when you looked at the comparison between those that were infected and vaccinated versus those who were not, the vaccine efficacy was about 40%. This is the most recent data. So then again, it works. I think this is pretty interesting information. Regarding the other effects it could have, so not just against illness, but also hospitalization, lots of studies, and I'm sorry, I'm showing you this just to make the point that we have a lot of data on influenza, right? So no worries about looking at the specifics, but in the last, several years since 2004 to 2016, throughout the world, not just in the US, when you look at decreased hospitalization in infants, maternal vaccine is effective, different variables, but it could be up to even 90% effective in decreasing hospitalization, so severe disease. And an interesting point of what we have learned. So moving on to the fact that it works. How long is it going to work? This is critical, and we've talked about the kinetics of the antibody. This study in Mali shows it very nicely because you can see how, here you have moms were vaccinated, remember, in the first 2 months of life versus 2 to 3 months, and then 4 to 5 months. The vaccine efficacy drops from about 66% in this study down to 46, down to 8% by the time children are more than 4 months of age. And this is correlated directly, as you can see, with the antibody decay. This is the vaccinated group where you start out with this level of antibody at birth that comes directly from the moms, from the placenta. And then by 2 to 3 months, it decreases quite a bit. This is the placebo or the control group, the meningitis vaccine group, where you don't have that elevation. So yes, this is that window of vulnerability that we saw before, where you do have that protection. Unfortunately, though, the titers drop very quickly and you lose it very, very fast. This is the study in South Africa where basically you see the same thing. This is the first 8 weeks of life, 85% vaccine efficacy, drops after 8 weeks to about 25%, and it correlates with a decrease in antibody concentrations. So I think this is very consistent. It's not a long-term solution, but it works. And last point about influenza is that it's safe, okay? So again, I'm just showing you a big table with studies that span from 2005 to 2018. I looked at this before the pandemic, and I was, this was one of those where I said, vaccine is safe in pregnancy, and I started to get those emails saying, are you crazy? What are you saying? But then other people have shown the same, that if you compare it either, with unvaccinated or people given other vaccines, in general, there's no association with any problems. There was at some point a signal about association with spontaneous abortion that came out recently. That actually was followed up by another study that showed, from the same group actually, from the VSD, that showed that it actually did not pan out when you look at the data. So far, vaccine is safe, okay? And then I do want to share with you, this just came out for the first time because of those 4 studies that I just showed you. Although they were not studies to look for an indication of the flu vaccine in pregnancy, they have actually resulted in the update of the package insert for the flu vaccine, one of the flu vaccines that is available in Europe, only for Europe and Australia. And so now it says therapeutic indications, active immunization of adults, including pregnant women and children, and actually also an indication for the passive protection of infants from birth to less than 6 months of age following maternal immunization. First time ever, this is a breakthrough because it will help the utilization of this vaccine in places where there are concerns. All right, I'm going to shift very quickly to the other 2. So I'm going to talk about pertussis. Everybody here knows a lot about pertussis. California has been at the forefront of maternal immunization and interventions, and you know the story. 2012, more cases than ever, but in the last 3 decades, neonatal mortality, this is the 0 to 1 month olds, continue to increase. So the most immediate intervention was to vaccinate the pregnant women to protect those babies in the first month of life. And indeed, not just us in the United States, but many countries, as I mentioned, have implemented it with different implementations in terms of the time, but all of them looking at vaccination after 20 weeks of gestation in the pregnant mothers. It works. Like I said, this is data coming from here, from California, where you start looking at 2010 to 2015. So you here had the outbreak before the recommendation was in place, and you started doing this before the recommendation was in place. And you see that if you vaccinate during pregnancy and at least 1 week before delivery, 91% effectiveness for preventing pertussis in infants. And certainly the effectiveness decreases if you vaccinate before pregnancy or even after pregnancy. This was the cocoon. So this is also what led to say, well, the cocoon really is not the most efficient way to protect babies. It's a, after the baby's born, if you can do it. But 91% is important to remember. In terms of the severity of disease, vaccinating pregnant women might not completely prevent infection, but it does decrease the severity. So you see here the vaccinated group versus the no vaccinated group. If the babies get sick, you have a significant decrease in hospitalization and ICU admissions, and you also have less morbidity with no seizures, intubation, or mortality in those babies. Also data from California. And the reason I say remember the 91% is because if you look at data from the UK, when they did this and they have a very nice health system in place with good surveillance and follow-up, you see that they have basically the same outcome, about 91% or more in terms of effectiveness. This was a temporary intervention in the UK, and after looking at this data, they decided to continue this maternal immunization. You see how in the UK, they were having more and more cases. This is of hospitalization of babies under 3 months. And after the implementation of maternal immunization, this has significantly decreased. And if you look at the mortality, especially under 3 months, you see that it had increased up to 2012. And again, you still have some mortality happening afterwards, but none of them were children whose mothers were vaccinated. And the ones that were, so these 2 right here, it says less than 3 months mom vaccinated. It was because the vaccine was given in a short period of time before the babies were born, so there was no time for the vaccine to be effective. So this has been really significant. But what have we learned? The one big thing that has come up with maternal pertussis vaccine is the issue of blunting, right? Have you heard about the blunting of immunization, of infant immunization? So this is a study that we did in Houston with randomized controlled trial of Tdap versus placebo. And just to show you the effect of pertussis toxin here, you have at baseline, moms had the same levels. Unvaccinated stayed the same at the time of delivery. Vaccinated had pertussis antibodies that rose significantly higher. You see the transplacental transfer is great. So babies born from vaccinated mothers had actually higher concentrations than the moms. These remain the same. Significant drop, similar to what we see with pertussis. So by 2 months, that drops, but still significantly higher. The problem is that if you look at after primary immunization, those infants of mothers who were vaccinated have a lower geometric mean concentration. It's still high, so they do respond, but the titer concentration seems to be lower than those infants whose moms were not vaccinated. And then we follow them until their booster, and you see that, again, they do boost, so they do go high, but it's still a little bit low. So that started to raise the question of, by giving these and having the maternal antibody, we're interfering with the infant immune response. And that's for TT. You see that we saw the same thing with FHA, another one of the pertussis antigens. You see that increase, and then is this lower antibody concentration. And as a matter of fact, I just warn you, I'll show you a very busy slide, but other investigators, not just ours, but all other investigators throughout the world have done the same. And this is an abstract that was just presented at ESPID by Baha Aburaya, who did a meta-analysis and looked at all these studies. And what you can see here is that anything that is going to be to your left is going to be consistent with interference or blunting of the immune response versus no interference to your right. And these are all the pertussis antigens, so PT, FHA, Protactin, and Fimbria. And you see that consistently, pretty much in all the studies, you see that potential interference. So we know it's happening, okay? It's there. The same thing, this is with the booster, interestingly. This is some of the new findings. We knew it would happen with the primary immunization, but it seems like even it persists until the booster, maybe except for Protactin. And then I wanted to show you for the other non-vaccine antigens, so heterologous with DT. This is for diphtheria and tetanus. Diphtheria, there seems to be interference, not so much for tetanus. There's no interference. This is after primary immunization. And this is with the booster, where again, tetanus, there's no problem, but diphtheria there is. So the question here is, what is the effect going to be, right? So we know the concentration is lower. We know there's some blunting, not just for the vaccine, but also for other antigens. And one of the big concerns here, for example, is pneumococcal. And you see that for 7 out of 13 serotypes in the pneumococcal vaccine, there was also potential blunting. Is this going to be causing problems with these diseases in these babies? So far, this is being observed, and we know that the trade-off is that, of course, we are not seeing neonatal mortality from pertussis in the first 3 months, which is where we had the problem. But the intervention might actually shift the risk to an older age. And again, I have to share this with you, thanks to Nikki Klein, who was so kind to share it with me, here from California, Kaiser Group, and doing research that is trying to address this question, because here you see how, and she looked at the pertussis rate in different ages in the first year of life. And you see that before the maternal immunization, you had the peak here in the first 6 months of life as expected, with less disease later on. After the intervention, there seemed to be a little bit of a peak here at the 6 to 8 months, but definitely an effect of the intervention with a decrease in the incidence of pertussis in that group that we were trying to protect. And the question was, are we then going to continue to see an increase in those where you see the blunting of the immune response? And what happens is that you see 2016 to 19, there's a flat line. It has not, at least for now, seemed to impact disease in the old kids. So this is really important. She presented this at the Bordetella meeting. I know this is to be published, but this kind of epidemiologic data is what's going to answer the question about potential effect of the blunting or not. Right now, we continue to vaccinate, okay? All right, and then I'm just going to say the other point that we have learned is the optimal timing. This is also Baha Buraya, who looked at different concentrations of antibody depending on the maternal gestational age at administration, and the highest time point was when you give the vaccine between 27 and 30 weeks of gestation. So we tend to favor the early second trimester, and that has resulted, at least in the UK, when they moved up to an earlier time, they actually started vaccinating at 20 weeks, a higher coverage, so a higher window allows you for better protection. I'm going to tell you briefly about something new, maybe in the last 5 minutes, before hopefully we have a little time for questions, because this is what's coming up in the future. So RSV is a big problem in pediatrics. We know it's actually worse than flu. Hospitalization mortality from RSV on a given annual basis is very significant for pediatrics. So we know that. And the fact that we have the majority of the disease happening in the first 3 to 6 months of life is what makes it attractive for maternal immunization for all the reasons that we have mentioned. So I will not elaborate too much on that. Which vaccine to use is probably the most important development that we have had in RSV, because indeed there's been research going on trying to have a vaccine for RSV either for children or for maternal immunization for many years. But for pregnant women, it has to be a non-live vaccine. And the definition of the antigen, so the pre-fusion F protein. So F protein is what allows the virus to attach to the host cells. And once it attaches, it changes to a post-fusion conformation that you can see here, basically results in the exposure of different types of epitopes or places where your immune system will recognize the virus. And these epitopes have different, elicit different antibodies with different neutralizing potency. So the goal is to target those places where you have higher neutralization activity. So the vaccines that are being, I'm going to just jump from that, are being developed right now are looking at targeting those. And we have had a progress made with a vaccine that is focused on the F protein. It's a nanoparticle vaccine where you see the vaccinated women here, this is a pregnancy study, have higher concentrations of antibody than placebo to those types. And similar to the figures that I showed you, you have, compared to the placebo, very nice concentrations of antibody. So this first phase 2 study allowed the progression to a phase 3 clinical trial, which is really the one that I want to show you. That was really just finished this year and presented recently at the European Pediatric Society meeting. And you see how this phase 3 study is looking at reducing medically significant lower respiratory tract illness. A lot of sites, you see a lot of the patients came from South Africa, about a third came from the US, but also global participation. And the goal was to, again, look at RSV-specific medically significant illness that could be reduced by maternal immunization. So I'll show you here. We have a very nice antibody response. This is the placebo group. This is the vaccinated group on the mom side with a good response of 99% and fourfold rises in the majority of the women. You see the same type of curve that we mentioned before where the babies or vaccinated mothers have high antibody concentrations, but then unfortunately by 2 months to 3 months, they drop. So a similar effect that we see. And what is interesting is that this vaccine, you might have heard already, unfortunately did not meet its primary goal. So you see the primary objective here was decrease of medically significant respiratory illness, and it missed it because it has, it didn't meet the confidence interval criteria. It protected 39%, but it did not. So unfortunately, this vaccine, although it made it to phase 3 clinical trials, is not going to be approved in the United States. And even though it was able to reduce significantly hospitalizations for children of vaccinated mothers. One important observation is that, and I'll just go to this point right here, is that when you look at all-cause lower respiratory tract illness, there is also an effect, and this effect actually lasted up until 6 months of life. So interesting to continue to think about it. This vaccine, it's likely to continue to be studied, even though it's not going to be licensed yet. Okay, I just wanted to show you here what that looks like in terms of the effects that you see. It's mostly in the first 90 days of life. So the reduction of medically significant respiratory illness. This is the number of people with not having the event. It's protective here for the vaccinated versus the unvaccinated. And the same thing with severe hypoxemia. And lastly, here with the hospitalization, you see that protective for hospitalization in the vaccinated versus the unvaccinated, but it did not meet their primary criteria, so not to be approved. We did learn with this study that earlier vaccination, so before 33 weeks of gestation, or a greater interval from vaccination to delivery of more than 30 days, actually results in better transfer of antibodies and actually increased efficacy. So it did help provide information about the timing. And of course, the vaccine was found to be safe. Breast milk, this is one I didn't show the group yesterday, but I have to say we do have a little bit of data of breast milk antibodies because people asked that. So Julie Shakib at Utah did this. And you see that if you look at IgA or IgG, the vaccinated group at all time points, especially at delivery, had significantly higher concentrations of these antibodies. And the same is true here for neutralization antibodies, although later on it's a lower quantity. So potentially protection through breast milk as well. Okay. And these are the vaccines that are coming along. We have more vaccines that are going to be evaluated for maternal immunization for RSV. This is the one that failed, unfortunately, but there's more to come. And here you have other subunit vaccines with adjuvant or without adjuvant that are now starting phase 2 trials. So these vaccines will continue development. And the last thing I will say is GBS, because I promised you I will tell you that. Group B strep is the next frontier. Studies were done in the 1980s already looking at either monovalent or trivalent vaccines against the most common types. But now the challenge is to include all of the important serotypes, which there could be 5 or 6 of them. So proof of concept has been there. I'll be brief about this because we have had some studies that show that there is transfer of antibodies and such. But I just want to show you the potential impact of having a GBS vaccine could be in terms of preventing disease in pregnant women, fetuses, and infants. The burden in Africa and in other countries in the developing world is significant. And one added benefit of having a maternal vaccine is that you could also have decrease in infants and stillbirths. And we tend to forget stillbirths. And stillbirth is a very, very big problem, again, especially in the developing world. So that could be the effect. And so to make a long story short here is that there are vaccines in development. There are a couple, a multivalent vaccine that is a hexavalent vaccine that is to be starting clinical trials soon for pregnant women, and also this other vaccine here, which is adjuvanted or unadjuvanted, and a roadmap that the WHO has put together to decrease this disease. That might be coming up later in time. This is one of the main things. You know, what has happened right now is that immune correlates are being developed, definitions are being developed, and what is it that we need to do? This is the hexavalent vaccine that I showed you. These studies are going to be in the future, the next thing to do in maternal immunization. And I will not like to leave without reminding you that maternal immunization is an opportunity to really make a big impact. You probably have heard what's happening, big outbreak of Ebola. Since February this year, pregnant women were added to the group that is receiving Ebola vaccine in Africa because of that risk-benefit situation. These vaccines were not developed for pregnant women, but after considering all of this, you know, while there may be some risk involved with vaccinating the pregnant and lactating women, the risk of the Ebola is so much greater, back to this, that we need to vaccinate. And if you consider other diseases that are like this, Lassa fever has to be in our radar. Lassa fever causes 80% maternal or fetal consequences, death or morbidity. And the other one is hepatitis E, where about 30% of pregnant women will have adverse events. So in the near future, you can see there the point of maternal immunization being particularly important for these diseases. So this is where we are. This is my final slide, where you see we have existing vaccines, which we use and generally recommend. We have the option of using a number of vaccines that are safe. The only vaccines that are being developed specifically for pregnant women are GBS and RSV, which is its own path, and hopefully, you know, we'll get there. But you see the opportunities for research. I like to say every shot in the arm of a pregnant woman is an opportunity to learn, an opportunity for research. Even if the vaccines that we already give, we need to continue to learn more about them, as you see. And then we can develop other vaccines that we can use for pregnancy. And with that, I'll finish. Thank you so much.
Thank you, Liz. We can have time for a couple questions if there are any.
I know, I'm sorry. I used up all of my time.
You just had a lot. Yes, go ahead, David.
So what's the evidence that the whole vaccine was more short time compared to the acellular vaccine advancing?
Okay. So the question is what the evidence that the whole cell pertussis vaccine was more effective than the acellular vaccine when given to pregnant women.
Is there any?
And no. So no. So just to clarify, right? So normally you don't want to give the whole cell to anybody over age 7. So the acellular came up because of that reactogenicity that you would have with the whole cell. When I mentioned whole cell vaccine given to pregnant women, that was in the 1940s when that was the only vaccine that was available. And there was so much neonatal disease or early life disease that it was, you know, an attempt to try to decrease that. The evidence is different from what we have right now. It was really trying to measure antibodies. It was a very reactogenic vaccine, so clearly these women would have a lot of sore arms and all that. But again, there were no studies like we have today at that time to follow up the babies and look at efficacy, because the vaccine was introduced in babies as well, and the babies respond well, and that's how we almost got rid of pertussis until we started using the acellular vaccine in the US and other countries as well. So it was really, from a research standpoint, it was a way to try to look at that option, but it was not necessary and it would have not worked because it was too much of a reactogenic vaccine. Yeah.
So I have one quick question around pertussis. I saw Nikki Klein's data, which looks very interesting.
Right.
And I guess the question is, do you think some of the epidemiology of pertussis cyclical epidemics or outbreaks have anything to do with that flat line that we're seeing in the last 3 years?
Yeah, so that's interesting because you see how pertussis is cyclical no matter what, and you have about every 4 to 5 year outbreaks. And so what we are seeing, and that's interesting because 2012 was a recommendation, so this should be a big year now in 2018, 2019, but it doesn't seem like we're seeing that big uptick anymore. And so I think it's working, and that is one of the follow-ups that data from California, from Nikki Klein needs to be, is that we need to look at beyond 1 year and over several seasons. But her data is from 2016 to 19. So, again, the biggest outbreak after that was before that was 2012. So I think we would have seen it already.
So you think we should keep vaccinating pregnant women?
Absolutely. For pertussis, please do. Not only me, other people think so too. Thank you.
Thank you.
Thank you.